So in terms of selecting the best treatment for patients as first-line therapy, probably the most common regimen that's being used now in the United States is FOLFOX plus bevacizumab, which has been the standard for quite a number of years now. Some people we might consider using FOLFOXIRI plus bevacizumab, and this is particularly for the patients with BRAF mutated colon cancer, or for a young patient where you're looking for a good response, somebody who might be able to go to potential surgical resection, ways to have an increased amount of tumor shrinkage. But we should know when we use more aggressive regimens up front, we should always remember to get patients into the maintenance therapies after about 4 to 6 months of treatment to allow them to have a better quality of life while they're still on their first-line therapy.
When we look at colorectal cancer, we know clearly that first line is pretty determined on chemotherapy plus bevacizumab. And for some patients on the left side with RAS wild type, BRAF V600E wild type, HER2 non-amplified tumors, there's the option also of adding an EGFR inhibitor instead of bevacizumab. In the second line really depends on what you do in the first line and some of the molecular profiling of the tumor. So if you're on the right side, chemotherapy plus bevacizumab is your first line, regardless of RAS or RAF status. Second line, in terms of what we have today available to us in clinic, it would be the switch of chemotherapy, continue the bevacizumab. If for the rare patient that may have a BRAF V600E mutation, you have the option of introducing a MEK plus a RAF inhibitor plus minus an EGFR inhibitor. We'll talk a little bit more about that later, but that's an option whether right or left side, although primarily on the left side. For the HER2 amplified tumors, again, preference would be for a clinical trial, including these HER2 targeted therapies. For MSI high tumors, which is about 4% of the patients, the preference is for a PD-1 inhibitor in second or third line. So most patients are going to go through 2 lines of chemotherapy plus a biologic, and it could be a switch biologic or a switch chemotherapeutic. So we end up in third line, and then we have 2 options in the refractory setting, regorafenib and TAS-102. Regorafenib is an agent that's a multi-kinase inhibitor. TAS-102 is a more traditional cytotoxic agent. It's part of the superfamily of fluoropyrimidines that specifically seems to work when 5-FU or capecitabine do not, in some cases at least. Both were compared to placebo in 2 separate studies. Both had very similar outcomes in terms of improvements. Historically, they look somewhat similar. Their toxicities are different: hand and foot syndrome reaction and fatigue with regorafenib, neutropenia and fatigue with TAS-102, and some GI toxicities in both. They've never been compared head-to-head, so it's very difficult to make inferences about which one should go first. And in practice, you have to think about your patient. Where do we have some data? We only have a little bit of data in the RECOURSE trial. We know that regorafenib given ahead of TAS-102 does not seem to affect the activity of TAS-102. On the other hand, with regorafenib, we don't have that sequential data. And mind you that with TAS-102, that sequential data came from essentially subgroup analysis, so it has some weaknesses to it. There's also the indirect inferences from 2 studies, TERRA and CONCUR, which used a less heavily pretreated patient populations, moved TAS-102 and regorafenib versus placebo in the 2 studies up the line. And regorafenib seems to essentially, historically at least, gain more power when you move it up the line. TAS-102 remained similarly effective across lines without differences, historically at least, in the deltas. So in my clinic, I tend to prefer to start with regorafenib first, followed by TAS-102, except for patients who have some mild liver dysfunction or patients who may have had hand and foot syndrome with capecitabine, and the idea of having, although the reaction is different, but there's still the idea of having hand and foot syndrome reaction is certainly not pleasant for them, and they would opt out of that option. So these are the two groups of patients.
There's a lot of discussion going on right now within the colorectal cancer field about what you should use first for your treatment. There's a lot of discussion particularly around whether or not to use TAS-102 or regorafenib first. Some people are concerned about toxicities associated with regorafenib, and so there's been some suggestion that if you use this first while patients are feeling better, they may have better outcomes. There was a very interesting randomized phase 2 Japanese study that looked at regorafenib versus cetuximab and which one to use first. And it really seemed to show that using regorafenib in an earlier line of therapy provided more benefit for patients. So this is bringing that question into play. Now, personally, do I use regorafenib before an EGFR inhibitor for patients with advanced RAS wild-type colorectal cancer? Not yet, but I think it begs the question that we need to look a little bit further into it.